debate, but it's coming back to our real world of day-to-day clinical practice, more on the wards than in ICU, although these principles can be used to some extent. My other disclosure is that I'm not an academic. I haven't published loads of papers, so the slides here will be a bit less complicated than the ones you've been looking at. Is there a problem? What should we be doing? Some guidelines, what we've done and how we've shown a difference. Paracelsus was the father of toxicology. He was a Swiss physician, and this is what he said. And I think that's true with fluids and drugs. Well, fluids are drugs, but if we give too much or too little, that makes it a poison or a remedy. And we have these posters up in our hospital. This work came from a report in 1999 of the National Confidential Inquiry into Perioperative Outcome and Death, which is done every year, and they focus on one particular thing each year. And in 1999, they looked at elderly patients, and they showed that about 20% of patients who get fluids have some kind of complication, not necessarily death, but some morbidity. And also that junior doctors weren't very good at prescribing fluids, mainly because they hadn't been taught very well. We've done a mortality review in our hospital, and there was another one in the Midlands, and showed, again, the 20% number slightly different, that 20% of the deaths had a contribution from poor fluid management, not necessarily causal. There was a report in Scotland recently that no hospitals chart fluids properly, and they don't prescribe them properly either. So it's a big problem, and we really have a duty to do something about that sort of level of morbidity. There's been some studies on fluid prescribing, and indeed juniors really are not supported very well by the senior doctors, probably because the seniors don't really know what they're doing either. Often we're given a pile of charts, and the nurses say, can you prescribe some fluids for these 10 patients? And the junior doesn't assess the patient, just writes down something, probably what the last person wrote down. And that's really not acceptable practice, but they're not given another option. What should we be doing? Well, you've probably seen this before. It's a phrase coined by Dilip Lobo in his research, and it's very important. And now all the information we've come across in the last 2 days has been trying to help us to do this. But on the wards, there's some simple things to follow that we can try and make this a bit better. We know that we retain fluid. We become overloaded very easily when we're under stress, trauma from surgery, even pneumonia, sepsis. We don't excrete sodium chloride, and we excrete too much potassium. And particularly in post-op patients, they can't excrete the sodium load that we're giving them. So they can become too wet. And if it hasn't been lost, let's not give it back, because we're just going to put it in the wrong place. And that's my very simplistic view of all these other talks that we've been hearing. Obviously, if they're too dry, they can get acute kidney injury. And on either side of the normovolemia, there's all sorts of bad things that can happen to you. What guidelines are there out there? Well, there are some NICE guidelines. NICE is the National Institute for Clinical Excellence in England, and Scotland uses the guidelines sometimes as well, but they're started in England. And it was Dilip Lobo, who's Professor of Surgery in Nottingham, who did quite a lot of work on saline, and he's very involved in these guidelines. It was based on the fact that things weren't going very well, that report that I mentioned, and there was increasing evidence supporting balanced crystalloid use. There were also some gift-a-sup guidelines, which were in 2007, but I don't think were really publicised terribly well or used very often. And it was these people whose names you see here, you might recognise some of them, were all involved in both sets of guidelines, and we now have the NICE guidelines from December 2013. They start with talking about salt requirements. It's about 1 millimole per kilo per day, and 1 litre of 0.9% saline has 150 millimoles in it. So really, we shouldn't be giving loads and loads of saline if we don't need to, but there are situations to give it. And we should also remember that most drugs contain quite a lot of normal saline as well, of salt. These are the requirements that NICE talks about, and we have to think of how we're giving fluids in the wards in terms of maintenance, replacement and resuscitation, and we can think of that in ICU as well. That means that if you're 80 kilograms, you get about 2.5 litres, which is what all my junior doctors used to say to me if I asked them how much fluid to give somebody, 2.5 to 3 litres. That's fine if you're 80 kilos. It's not fine if you're 40 kilos, and that's why it's so important to weigh patients. The NICE guidelines also have quality indicators, and they say that all hospitals should have a lead for fluid management. We should train clinicians and we should assess them, that senior clinicians should be involved, and that we should report errors due to poor fluid management, such as pulmonary edema, peripheral edema, hyponatremia, hyperkalemia. All of these are reportable if they're iatrogenic. Looking at all of that, there's an awful long way to go before we fulfil those requirements. And this is just a plug for coming to Scotland to visit. This is a beach in the Outer Hebrides in the island of Uist. What did we do in Fife? Well, it was a bit of a long process, and it's taken up the last few years of my life. But I started off, having heard Dilip speaking about this, doing some audits, then raising awareness amongst the people in the hospital. We got a fluid group, we got management involved. We put some guidelines out. This was before the NICE guidelines, but I knew what the NICE guidelines were going to say. Educating, and then the key thing was appointing a fluid nurse, because you can't do this on your own without involving the nurses. My third fluid nurse, Emily, is with us in this conference. More education, new charts, monitoring, and then gradually in Scotland people have started to take notice and say, oh, what's this you're doing, and asking us what's going on. So I'm not going to go through all my audits, but just a summary. Basically, everybody got too much salt, up to 800 millimoles a day, not enough potassium in half the patients, either too much or too little fluid in 60%. And I also did these were on the wards, these audits, and ICU and HDU. Also did just a small study of elective surgery patients, and found that actually a lot of the anaesthetists were giving far too much fluid as well, despite all the evidence that's out there that it's bad for you. And I think you have to see that, you might think you're all doing the right things, but your colleagues might not be, and it's worth finding out. This was a bit more about our mortality review, and we did see the frail elderly coming to harm. Also, there was a lack of senior input, and interestingly, people who were put on a fluid restriction, so the doctor maybe in renal unit had come along and said, only a litre today, and they would get 300 mils because everyone was really scared of giving them any fluid, and that might do them more harm. How are we going to improve this chaotic situation? Well, we have to have some sort of guideline and a logical approach, because if juniors don't know what they're doing, seniors don't know what they're doing, it's going to be a mess. And your patients, when they come to ICU and you try all these fancy equipment, fancy things that we do in ICU, if they're already overloaded by 10 litres, then you're starting at a bad baseline. We've also restricted and standardised the fluids available to us. And we've done a lot of work in improving fluid balance charting. Lots of education, and that's constant because we have constant turnover of doctors every 2 or 3 months. There's new doctors, there's frequently new nurses, so you really have to keep on top of the education side. We did quite a lot of education for consultants as well. Same message. So what do our guidelines say? Well, first of all, what do you need to think about when you're prescribing fluids? You have to assess the patient. There's no point in just filling something in without knowing anything about the patient. Do they need fluids at all? They might not need them. And why do they need them? Is it maintenance, replacement, or resuscitation? How much fluid and which fluid are you going to give them? And what we use, it's I'm saying the right fluid. That's what we've decided to use on the basis of what NICE has recommended. You don't have to use that. There's all sorts of other alternatives. But I say to my juniors, if you're on a desert island and you were thirsty, you wouldn't go and drink seawater. And we wouldn't drink a salty water out there for coffee. So we want to give people mainly water if it's just maintenance fluid. And this solution has the right amount of sodium, the right amount of chloride, and the right amount of potassium, and it has some glucose if you give it by weight. We were a bit worried about hyponatremia because this was the first time really people in Britain have been giving this as a maintenance fluid, and there was lots of worry about that. So we said that if your sodium's less than 132, then we use a balanced solution for maintenance. Now, I don't know the evidence behind that, but at the moment we've not had any trouble with hyponatremia from the 0.18 and 4. I haven't been giving it to people who are hyponatremic, so I can't tell if it would make it worse or not. I suspect if you give the right amount, it probably wouldn't make a much difference. Replacement, we use a balanced solution, but there's a place for sodium chloride. And sometimes I use a bit of colloid in theatre, and sometimes in ICU we use Alba. The guidelines also have some information about all of these things. There are some challenges. We needed new charts. We found that across the hospital there were lots of different prescription and balance charts being used, so we standardised that. The nurses didn't have much feel for how important it was to fill in the charts, and also we didn't have any goals on the charts, so we didn't know what we were aiming for fluid balance every day or for fluid prescription. Also, we found that we couldn't do these changes without some funding, and I got a quality improvement grant to employ my first nurse. She did a lot of education, but her main point was to go around and test the fluid charts that we put in place, and I think we're on our 14th version before it was put out to the whole hospital, and we used QI methods, which you can find on the internet, PDSA cycles and such like. What about outcomes? Well, it's difficult to study something across a whole hospital. If you make a big change across a whole hospital, how do you see that you've made a difference? We should make a difference. If we're doing something better, if we're doing something sensibly, it should help. So that's not a very evidence-based statement, but if we're doing it better, it should help. We can measure what we're doing. So we can measure, are we prescribing the fluids we want to be prescribing? Are we monitoring the balance charting the way we want to do it? And we can measure changes in blood tests. And indeed, we're in the middle of a study looking at blood tests across those whole 8 years from before we did anything to afterwards. And I'm hoping, I'm not sure, but I'm hoping it will show some improvement. It may not. Certainly the culture of fluid prescribing across the hospital is much better than it used to be. This is just a chart from the early days of the charts. In an orthopaedic ward, people were getting roughly about 15 mils per kilo per day, and after we put the charts in, did some education, obviously there's variation, but the mean amount of fluid did improve. Then we can get data from pharmacy, and that's very easy to get. And what we have shown is that before we started all this work in 2009, we were using 8,000 litres per month of 0.9% saline, and that's now down to 1,500 litres per month. So we've made a difference in terms of what we're using. And then if you look at this, it's even more unexpected from what we thought. So at the beginning of the work, 0.65 litres per occupied bed day, 0.35 now. So we've cut the amount of fluid we use across the whole hospital almost in half. And that hopefully means that our patients are less overloaded and should have better outcomes. And we asked the junior doctors what they thought of the guidelines. And we have junior doctors coming from all over Scotland. And they all used them because they're on the prescription chart now. And they said, it's changed what I'm doing, and actually senior doctors are getting more involved, and it makes me think more about what I'm doing. So I think we've made a difference. We've changed the culture. Undoubtedly, people talk about fluids. They know that it's an important thing. We have lots of support. We didn't have much opposition from consultants at all, in fact. We've got new pumps. And just last week, I had a meeting with the Scottish Government, and they said, we want to do this all over Scotland. We're going to give £600,000 split up between all the hospitals in Scotland, and that hopefully will mean that each hospital can have a fluid nurse and some consultant time to put this into place. That's my contact details if you want any material electronically. We also have on the white sofa over there, we've put some guidelines and fluid charts out there, so please help yourselves if you'd like to. Thank you.